Thank y'all. So thank y'all so much. Hi, Dr. Ford. Thank y'all so much for having me here today. It's really good to be in this building. So I was a student at when we were in the other building back in 2012, 2013. So it's really good to be back. I love coming back, and I recognize a couple of people. I think I may have been in your educational theories course. Dr. Byers asked me to come one day. For some reason, you're looking very familiar. So it's really good. I always love coming back. So thank y'all for having me here. So I finished my master's in 2013 and started teaching at Tech in that same time period, and fell in love with simulation in the research class that was here. Really started getting into what's the literature behind simulation, and so very frequently, if you follow me or anything like on Twitter, I hashtag more than a mannequin. Because for the longest time, I thought it was really about the mannequin and the high fidelity and the technology. And as I started doing my work in my master's program, I really began to understand that there was a full pedagogy and science that supports how we teach with simulation, not just there being this mannequin in the room. And so looking into, just a little bit about myself before teaching at Tech. I was a cardiac intensive care unit nurse. I worked with Grace. And I was frequently found in situations where we would care for patients with therapeutic hypothermia. And I just remember this critical moment where I had been through the training for therapeutic hypothermia, and I think about 7 or 8 months later was the first time I was caring for a patient who was in a very critical state, undergoing a lot of difficult things, and here I am struggling to understand, okay, now why do I need to have this met by this time, and trying to refresh myself. And so that kind of threw me into the literature on how do we learn best, because I recognized a gap in my own learning, and I realized it could have affected a patient. So luckily I had an amazing staff that helped me through that, but I thought, is there a way that we know we can teach better than the traditional lecture environment or things of that nature? And that took me directly to simulation. So I started looking into simulation, did a small pilot project here, and looked at can you develop a simulation for therapeutic hypothermia? And as I found out, you can develop a simulation about just about anything you want. It really comes down to how do you begin to debrief that. So as I started educating, I pulled a little bit away from therapeutic hypothermia and really just began to focus on simulation. So how many of you are familiar with simulation or the traditional simulation setup? You maybe in simulation as a student. So I was fascinated when I got to Texas Tech with these students that, the traditional clinical environment, every student is doing something. And without going into a deep dive on that, the thing that we recognize in the educational world, that the limitation in the clinical environment is, how many of y'all did the 1 to 10? Like you had your faculty, and there were 10 students, and you went to clinical in the traditional model. So you had your faculty, there were 10 of you, and I heard this person say, the limitation that we have is this term called education by random opportunity. So how many of you perhaps showed up one day to an experience and, or to a clinical site, to, let's say Covenant SI, and you had a patient that you had never had class on, you'd never read 10 paragraphs about, like, what is this diagnosis? I've never heard of this. But your peer, you sat in class all together and learned about DKA, and they show up to clinical and they get a DKA patient, and it just all fits. So the whole day, everybody's talking to that student about, oh, how does this fit? Because it's what's comfortable. And so even in post-conference. In post-conference, it's very likely that the clinical instructor is going to focus on what was learned in class and now how this came to life in clinical. And so while one student got this excellent, rich clinical experience, the other student, their patient got discharged and they got 2 new admits, and one was down in MRI for 2 hours. And so that was an interesting phenomenon to me. Where in sim, we have this controlled environment. So everybody gets the same patient. So I was pretty fascinated that in this situation, we might have 4 students, which we know is not characteristic, 4 students caring for 1 patient. So have y'all seen that in sim? You have 4 people playing the role of a nurse. And we know that unless we're like in a code or an admit, that doesn't really happen. It's just us. But then if you have a large school like us and Covenant and these large schools of nursing, very frequently you find a large amount of students in the observer role. And so they're sitting in a room, probably distanced from the actual simulation room, and they're watching it on a projector screen. They're watching the simulation unfold. After the simulation is done, they all come back together. So I was really interested in clinical, everybody's doing. We also know, how many of you had observer experiences in clinical, like where you were sent off on an excursion, and you were told you really can't do anything, you can't give meds, you can't do anything invasive, but we want you to kind of follow a nurse. Does that sound familiar? Like, I remember doing that in like the cath lab or like some specialty locations where they were like, don't touch anything, don't do anything, you're just here to observe, right? So there was this whole world that began to fascinate me about, well, how do we anticipate learning occurs for those in the observer role? So that led to me pursuing a PhD with a focus in nursing education, looking at what about these students in observational roles in sim? Because at some point I want to look at the observer role in clinical, but in a controlled environment, and if you've been through your research course, you know that we like control. I needed a controlled place to look at this. So this was a great starting place. So you'll understand as we go throughout this, all the observational experiential learning facilitated by Debriefing for Meaningful Learning. But to begin, let me get you into a little bit of this. This is my dissertation study. So first, let me talk to you about these 2 terms. So assimilation and accommodation. Does anybody remember these terms from maybe human development? So assimilation and accommodation develop early on. And so if you have kids, you've probably seen this. And there's a great picture that I have, and I should have probably put it on here, but there's a picture of a little kid looking at a 4-legged fluffy animal that is a dog and says, it's a dog, right? Assimilation, 4-legged animal. So this brings back all the schemas and all these things that, how we develop what a mental frame is. Well, then in the next picture, it has a picture of a cat, but the little child says 4-legged fluffy animal, it's a dog, right? But now it's a cat. So they learn to adjust their schema. They adjust their frame of reference. That's accommodation. So when knowledge fits previously existing frames, we call that assimilation. And when knowledge is counterintuitive to an existing frame, it's accommodation. So in the clinical context, here's how I would think of that. So if I told you that you were getting a report on a 85-year-old, 102-pound COPD smoker, she has, trying to think, very frail skin. You start developing this image, right? What that's going to look like. So we start developing this image of what we're going to see when we walk in and we begin to, thinking of this weak and frail individual who can barely stand up because she's so weak. So that would be assimilation if you walked in and found that to actually be true, right? If you walk in and she jumps out of bed and greets you, you might have to adjust. And okay, well, now then I see this. And we see this happen all the time. And you do this all the time in your nursing role. How many of you learned, sat in a class about, and I'm going to use a cardiac ICU example, where you learned strictly, you had paragraphs, you had assigned reading, you had assigned homework about people that are born with their heart on the right side of their chest? Especially in nursing school. Probably not, right? Definitely not something we would expect to have a full-blown class on. But the very first time that I listened to a patient's left side of their chest and heard nothing, and he's talking to me, and he said, "Do you hear anything?" and me being a nurse, like I was a nurse. I was a registered nurse at this point, not wanting to sound dumb. I said, maybe it's my stethoscope. Let me clean it out. And he's like, you're not going to hear anything. And I said, okay. He said, my heart's on the right side of my chest. So I think that my preceptor set me up because he didn't tell me that in report. But very quickly, you have to learn to accommodate. Very quickly, you have to learn to adjust your frame. When you're looking at a right heart cath of that, the heart is now on the right side of the chest. No one trained me to do that. You have to accommodate for what you know. And so what we've learned is that when we start teaching, assimilation and accommodation are what you do every single day. You adjust. You read something in a textbook, you read about what congestive heart failure looks like, and then you show up and you see a patient that has congestive heart failure and it doesn't really look like that, but you indeed see that the ejection fraction is horrible, but it doesn't look just like you saw it in the textbook. So we have kind of figured out in the world of teaching and learning that assimilation and accommodation are where we live as nurses. So I was really interested in that. The other A that I would add to this is anticipation. You also have learned to anticipate. And so we've called this before that gut instinct, that intuition. Like if you've ever called a physician and said, I know everything looks great, but something's not right. The only way you've been able to do that is through going through this process of assimilation and accommodation. Something before has triggered you to think, something's not right, I can't put my finger on it. But we don't imagine that anybody off the street could walk in and have that same gut instinct. We anticipate that it comes from you being able to adjust. You've adjusted for so long that you're picking up something that doesn't feel right. So that's where we are with assimilation and accommodation, and those are two terms that you might want to kind of hang on to. So assimilation being how things fit, and if it fits, it all clicks, and accommodation meaning I had to adjust because it didn't fit the previous thought that I have. The other thing that you're going to hear me refer to is the INACSL standards of best practice. So INACSL is the International Nursing Association for Clinical Simulation and Learning. So they developed a set of standards that says this is how you should do simulation. So if you hear me just say the INACSL standards, that's what I'm referring to. There are 9 standards that govern in education how we should do simulation. Oh, whoops, I'm changing my notes. Okay, background. So we have increased the use of simulation in pre-licensure nursing. So BS in education, we are increasing the use. I call this the triple threat to nursing education because we have increasing clinical, let me make sure I get these right. We have increasing student enrollment numbers, turning away more students. We have decreasing faculty. We are increasing now, but we have a shortage of faculty that are teaching nursing students. And we also have a numerous amount of clinical sites that are saying multiple schools are hitting us and we've got to cut you back. So that's kind of the triple threat that's hitting us. So because of that, there's been an increased use of simulation. In the national simulation study that was done in 2014 in 6 large schools, they replaced, so imagine you have 1,000 clinical hours. Is anybody familiar with the national simulation study? Okay, so I'm going to tell you just a little bit about it. Imagine that you have 1,000 clinical hours that you have to obtain in your BSN program. What they did in each site is they randomized each group of students in these 6 schools, and you right here got 10%, so you had 100 hours of those 1,000 substituted with simulation. You right here in the middle, you had 250 of those hours supplemented with simulation, and you over here, you had 50% or 500 hours supplemented with simulation. Across multiple data points, there were no significant differences at any ATI benchmarking exam, at any NCLEX pass rate in any school, on any manager's evaluation of students post-graduation. There were no significant differences, and in fact, in a non-significant way, the 50% group did better. So that kind of let us know we can substitute simulation for clinical, and there's not going to be a drastic difference in how they perform on NCLEX and how they're perceived by their managers and how they score on ATI benchmarking exams. So that national landmark study has catapulted the use of simulation. What we found in that study and throughout the nation is that most learners are observing. They're in the room observing via a TV. There's only 4 in the room, and 8 or 10 are in the observational role. And that was slightly troubling to me. I wanted to know, what about the observers? Simulation lacks support for theories that incorporate observational learning principles. So largely, if you've been through your educational, have you been through your educational theories course yet? So largely it's based on experiential learning, and that is learning by doing, and that's what it's equated with, learning by doing. Well, if most of our learners are learning in the observational role and there's an assumption that they're doing, then we've kind of violated this whole idea that we can support it with a theory. So that's where I said, current research has equated observational learning with experiential learning, in that the current research that's out there has numerous confounding variables in the exploration observer roles. When I talk about the Anaxel standards, there's neglect for what we're doing for these observers. So some observers are incorporated into the simulation. They can't do anything, but they can help the team. Some get checklists. Some get nothing. They just sit there and observe. And we actually know from the media literature, the advertising, so how many of y'all get pulled into those extremely sad commercials about like dogs and the Sarah McLachlan song that just makes everybody cry, right? But how many of you also know that you can completely have a conversation while a commercial is going on as well? We know that exposure to something does not mean attention to something. So just because you're sitting in here right now does not mean you're necessarily paying any attention to me whatsoever. Exposure to me does not mean attention to me. So when I even found that in the advertising literature, I was like, wow, we've made a lot of assumptions about all of these students that are watching this unfold on a TV. Because we know that students can do a lot of things while watching TV, right? We also know that when students are watching TV, their brain activity plummets. It's just like a flat line. There's some really cool work at MIT that says your brain, and have any of you heard of the flipped classroom? Is that kind of, okay, so there's a concern out there that we've taken this and put it on a voiceover, right? So and now we have TV meets lecture, and in both places, students' learning plummets. So there's a concern about that's out there that's pretty well supported by some researchers at MIT that says when you're busy or when your attention is grabbed, your learning starts to climb. So that was again, if you've done your review of literature, you kind of start diving into literature. I started finding amazing things in the advertising world, in the technology world, in learner styles. That was pretty fascinating. I keep changing my own. So I started to think of a study. And my study was to explore the relationship between pre-licensure baccalaureate nursing students' roles in simulation, the active participant, the nurse that's in the room, or the observer that's watching outside, and cognitive knowledge demonstration, retention, and application, assimilation or accommodation, to a similar clinical situation using simulation with debriefing for meaningful learning. So how many of you have been part of a debrief? So there's a way that we're supposed to debrief, and one of those is through Socratic questioning: who, what, when, where, and the infamous why. Why are you doing that? Why do you do this? there have been two people that have pretty well-established methods for debriefing. One is the Harvard group. So the group at Harvard, they train physicians, anesthesiologists is a really big focus for them, nurses, pretty much anybody and everybody. And they use a specific method of debriefing that has been shown to increase clinical judgment and reasoning and this whole idea of anticipation, assimilation, and accommodation. There's another one that's well supported that was used in this national simulation study called Debriefing for Meaningful Learning. So there's two really well supported methods of debriefing that if you follow the structured process, you get similar results. So when I say debriefing for meaningful learning, I'm talking about one specific method that was developed to help learners in simulation get guided through what happened. And if it was kind of like me, debriefing was kind of emerging when I was going through my BSN program. And so it was really a focus on, well, so what went well? What didn't go well? And what would you change, right? So now then it's a little bit more probing. So if I'm in a debriefing now, I might say something along the lines of, I noticed that you gave 80, well, I'm just going to use something out there. I noticed that you gave 80 milligrams of morphine in the simulation, and I'm thinking that that would have likely killed the patient. So I wonder if you could explain to me why you drew up 80 milligrams of morphine. So very direct, because this idea of kind of sugarcoating the good, the bad, the good, means that we kind of sugarcoat an error in the process. And so we're quite a bit more direct in debriefing now because that's been supported. And so when I talk about debriefing for meaningful learning, it's a very directed way of asking questions to get learners to talk. Rather than yes-no questions, we're really looking at getting them to talk more and me to talk less. Because when they do that, they start telling us, well, this is what I thought was going to happen, and this is why I did that. And then we have more to kind of uncover. So simulation, the observer role in simulation has been somewhat supported. So far, there's been some small studies at different universities that have said there's not a lot of difference between them. There's a lot of limitations in that they didn't evaluate the instruments that they were using. They didn't, or they what I call mimicry. They did this thing called mimicry. So they found out that, well, you were the observer, so I'm going to pre-test you and then let you observe, post-test you, and then put you in the sim right afterwards and do the exact same sim again and see how well you do. And well, there's no differences. And my argument against that was you could have just been mimicking behavior. We all know that if we see someone do something, we might just mimic them. And if during the debrief you were told, well, don't do this, then the next time that you did it, which was 30 seconds later, you're not going to do it. And so my argument against some of the literature that was out there was they didn't have tests that were evaluated, and that they also violated quite a bit of what's out there for the observer role, and that's having them mimic the behavior or things like that. When I begin to look at learning through observation, this was probably one of my most fascinating findings. So if you choose to go on for a PhD, they'll ask you to explore the literature outside your field. And what I found is that the world of exercise science has done some really cool work in this. So if you talk to any 5th grade basketball coach, they will tell you that to teach a free throw, they have everybody watch a peer, and then afterwards they go and shoot, like the coach does. And if you've ever taken, I did this one time, and I'm still not a good golfer, but I went and took golfing lessons. And so what they did is video recorded me, and I had the golf club. They asked me to take a swing. They found somebody with a similar frame, build, height as me, and overlaid them on my picture. And so then what I was sent home with was this video to compare and contrast the difference between the expert swinger that looks just like me and the novice swinger. And so what they found is if you want to learn how to shoot a free throw, it's really good to watch a novice and watch an expert, because in that, your brain does some pretty cool things. When you are watching an expert, and you know it's an expert, so if you're watching Patrick Mahomes throw a football, you're going to trigger these things called mirror neurons to mimic that behavior. I want to mimic it. If you're watching me throw a football, your cerebellum kicks in for motor control to not do those. Just like we ask someone to slide their heel down their shin, right, when we're looking for cerebellar dysfunction, your cerebellum kicks in when you know you're watching a novice. So there's a lot of research that says if I trigger the mirror neuron followed by the cerebellum triggered by the mirror neuron and do that over and over and over again, this is what athletes do. They go back and forth to the point that they're so close to the expert that they're watching themselves and they can watch themselves and pick up on the differences. So I thought that was really fascinating on the work that's out there on observational learning. There's a lot of work on mental imagery. It turns out professional Olympic athletes do this all the time before an event. They visualize themselves going through it, and many of them can tell you, I knew before I started that it wasn't going to be my best performance. And I just thought, there's a lot out there. We sent y'all to observational experiences. We sent you to watch an expert nurse, but we didn't prime you for, remember, this is the expert. Watch the expert. And so I think a lot could be done, even in the teaching and learning environment. What I tell my faculty a lot of the times is, how many of you y'all did sim? How many of you, most of the time, watched your peers do the sim? How many of you ever saw your faculty run it? You did. It's very few and far between that you actually saw the expert. You know, I think about, I'm going to use Grace as an example. I would have benefited as a brand new CI nurse from watching my 7 that went through the internship care for a patient in therapeutic hypothermia, and then right after that, watching Grace care for that. Because you're the expert, and I know you're the expert, so I'm going to change my frame of reference to know, oh, I'm not going to do that again. I saw my peer do that, but then I saw Grace handle it this way. So we all know those experts that are on our units. We all know that I could benefit from seeing that person. No one wants to admit to being the novice, but at the same time, we all know that we're novices at some point. And so I always think about that in simulation is we haven't explored that yet. There's been no exploration of actually getting the faculty and what we can do through observational learning. So I'll talk about observational experiential learning here in a little bit and then how I facilitated it on the next slide. So you've been through theory. And when I taught to the educational theory course, I sometimes feel like when we hit the word theory, our brains start losing attention because we're like, it seems so abstract. And I remember thinking the same way. I was like, that sounds like my timer's up. I remember thinking, I don't know if I'm ever going to understand how theory supports all this. Well, in my review of literature, I stumbled upon this term called observational experiential learning. And no one had discussed it in the nursing world. It's all been discussed in the business world, which was shocking to me. So I got to draw my own. And I tell you, this looks really pretty now, but this was probably the 50th drawing. And I have the book of drawings because somebody told me, just save them. This took a long, long time to get to with a lot of help and a lot of teaching and a lot of literature review. But in the middle, in the green, you will see Kolbs Experiential Learning Theory Untouched. That is Kolbs Experiential Learning Theory in green. So as you can see, what we assume is that the concrete experience in the left green circle is viewing the simulation or participating in the simulation. You have either been an observer or a participant. As you move on to reflective observation, when we get into the debrief, the reflective observation, the abstract conceptualization, and the active experimentation phase are all areas that we have support that occurs in the debriefing. So as you can see in the top right corner, if I ask you, so tell me what happened in the simulation, and you say, well, I raised the head of the bed, and I say, well, why did you do that? We're developing assimilation. We're developing how knowledge fits. So, okay, I see that, when a patient is short of breath, I'm using this because we all know that this is the one thing all nursing students do when they walk into a room is they raise the head of the bed because they're all going to be short of breath. So they assimilate this, right? So I'm going to ask you, you say, I raised the head of the bed. Well, why did you do that? Well, so that they would breathe better. Well, why do they breathe better? And that's usually where they get stumped. So, right? So we probe and we ask why, and we get them to fit knowledge about today's simulation. The active experimentation is now I say, well, what if the patient has a spinal injury? And they're short of breath and they're laying flat. What are you going to do, right? That's how in debriefing we get them to adjust their frame. Like you can't just sit this person up now because they have a spinal injury. So this is what we do in sim now is we think of the what if. Well, what if they had a spinal injury? What if they can't sit up? What if that doesn't work? I mean, all the what if questions that we can, where we try to get them to think about another situation where it could be applied that's different than what they learned today. And that is when I'm working with students, and if a debriefer has been trained to work with students, that is what their goal is to get them to think, well, what if this? So that if they're in another situation, they can adjust their frame of reference. So what I added to Kolb's experiential learning theory is in the orange. The orange are 4 constructs from Bandura's social learning theory. So he says that to observe, you have to be attentive and you have to be motivated. So again, going back to the literature around what keeps you in a concrete experience as an observational learner, what keeps you in it. If you're attentive and you're motivated, you can learn just as much through observation as you can through doing. And then he also has the 2 constructs at the end on both sides of the motor reproduction or the behavior reproduction and knowledge retention, so the cognitive piece of how we retain knowledge. If you look at the red line in the center, the red line that's going through the center, that is the grasping of an experience. So the best way that I have to explain this is if someone were to say to you, research brown bag, and you leave and go home and your spouse or whoever says, well, tell me about the research brown bag. You're in a concrete experience, and when you describe it at home and recreate it, you can tell people, this is what to expect when you go to a research brown bag, right? So the active that is grasping an experience. The ability to grasp an experience is being able to describe it again after being in it. So you can use this for driving. I think driving is a good example that tends to work well. So driving, so you can be in the experience and you can go home and tell people about driving. The active experimentation and transformation, or the reflection, is described by the vertical pole. So that is the transformation of an experience. And that's what we want, is a transformed experience, to apply it to learning. So you've grasped this driving experience, and now then, for the first time, you're driving on ice. Right? So now then you've changed everything, and you're having to apply all of your principles about braking and speeding up in a new situation. So that's what we try to do in sim again, is by having a grasped this experience that you just experienced. I'm going to what if there was ice on the road? What if there was fog? What if this patient had a spinal injury? I'm going to keep doing that until I help you adjust that frame. So my hypothesis is we could measure this. And then at the center in the purple, you'll notice that that's Kolb. Kolb says that experiential learning is not just doing the experience, it's going through all of them. And the way I was going to make this happen was through Dr. Dryfurst's Debriefing for Meaningful Learning method. So, the design. So this was an experimental pre-test, multiple post-test, repeated measure study. So by an experiment, I had manipulation, and I had total control of the experience. I had randomization. So the students, although I had 120 students in my study, which you'll see there, they were not placed in their clinical groups by anybody. They were randomly assigned by me. And they were randomly assigned to the role of participant and observer. So it was completely randomized. It was in a multi-campus health sciences university school of nursing, so you can probably guess where that is. 2 sites, and I'll just go ahead and say here those were in Lubbock and Abilene, because we have two campuses, and in an accredited simulation center. I won't go too in depth for the power, but I was able to well power this study. I had 121 that were invited and 119 that agreed to participate in the study, 76 in one site, 43 in the other. Once they were randomized, I had 59 active participants and 60 observers. So the simulations were done in groups of 6, with 3 in one room and 3 in the other, or 3 in the observational room and 3 in the role of the nurse. So the research questions, so bear with me here because they're lengthy. Is there a difference in knowledge demonstrated and knowledge retained by nursing students in active participant versus observer roles after a simulation about the care of a patient with respiratory distress? This respiratory distress case was an opioid-induced respiratory depression case. At baseline, before and after debriefing with Debriefing for Meaningful Learning, and 4 weeks later. The second, is there a difference in knowledge demonstrated and knowledge retained by nursing students in active participant versus observer roles when applied, assimilated, and accommodated to a parallel case about a patient with a different kind of respiratory distress, which was anaphylaxis, after Debriefing for Meaningful Learning and 4 weeks later? So, how did I come up with those, you ask? I needed to find 2 related cases. So, bear with me for a minute here. Assimilation, or the scenario that all students went through, was called the concrete experience instrument. I was looking at how knowledge fits together, or assimilation. It was based on the simulation that they actually went through. So this was a case of an opioid-induced respiratory distress. This patient was a 47-year-old female in a world that I don't know too well. It was in the not postpartum, but in like women's health. She was post-op. So I do know the post-op world, but she was a post-op hysterectomy. And after she's in the recovery room, she gets a dose of morphine and she goes into respiratory distress. So we all have a picture of that, right? Lung sounds are shallow and clear. Respiratory rate goes down. Heart rate's probably going to start going down and up a little bit. Blood pressure is going to go down. We start developing this picture, right? We need head of the bed raised, oxygen, probably via a non-rebreather, or if they go into too severe of a respiratory distress, bag valve mask, and an antidote, Narcan. Active experimentation, so anaphylaxis. And I know you might be thinking, okay, wait a minute, what? But bear with me. So we have an event. So now then, to develop accommodation, what I did in the debriefing, at the very end, every group that I had, after I got done with the debriefing, I went into the final phase where we asked learners the what if. So they did not go through this sim. This was what if, after you cared for a 47-year-old female, post-op, hysterectomy, you have a 9-year-old boy who gets stung by a bee, and they present to your clinic and they begin to cough and wheeze. What would be similar? What would be different? So as they start discussing, first one, well, they need an antidote, right? So that's similar. We need an antidote. They're going to need oxygen, okay? So those are 2 similarities. What are the differences? Well, their respiratory rate's going to probably go up, and their lungs aren't going to be as clear. So we guide them through that. So this was all a guided discussion. So what I did was develop 2 identical 10-question tests that at the beginning of one said, your patient is a 47-year-old patient undergoing post-op, hysterectomy. On the other one, the patient is experiencing anaphylaxis. So the best way for me to show you that is these are 2 identical instruments. However, to facilitate assimilation and accommodation, the correct answer changed on 5 of the 10 questions, and it stayed the same on 5 of the 10 questions. So in this case, the obvious one, the antidote changes. The lung sounds change, but providing oxygen via a non-rebreather did not. Providing, I'm trying to think there's a few other ones. I was able to come up with 5 and 5 that showed, hey, knowledge fits, the exact same and knowledge differentiates. So that's how I measured this. Here's my procedure. So on entry, they took their pretest for the concrete experience, for the simulation they were about to experience. Then I randomized them into their role. They went through the simulation in groups of 3, so I think I had close to 14 different simulation groups. Then right after the simulation, they took the post-test about the patient they just took care of. Then I did debriefing, and then I delivered both instruments, waited 4 weeks later, and delivered both instruments again. Does anybody have any questions so far? I know this is a lot. Maybe with all the instruments, do you have any questions on that? Okay. So what I did here is operationalize, and this is where I begin to love the theory. As you can see, the concrete experience is the sim. What I wanted to do, because we know debriefing is the most significant component of sim, I wanted to measure how they grasped the experience. Before I ever said a word in the debriefing, did you learn anything from the sim at all? Because I was curious, did my people in the sim that were actually doing the stuff learn from the sim? Did my people in the observational role learn from watching the sim unfold? Because I know in the debriefing, I'm about to guide them all, and the literature was clear that the debriefing is going to help all the learners gain the knowledge. So I wanted to isolate that. And that was the cool thing about research, is you can isolate whatever you want sometimes, especially in education. Maybe not in the real, in clinical world, you can't isolate everything. But I was able to isolate that. So again, we go back to research question 1. I had 4 different time points on this. So as you can see, research question 1 only has to do with the CE tests. CE pretest, CE post-test 1, CE post-test 2, and CE post-test 3. So that is the baseline before and after debriefing and 4 weeks later. Let me make sure. Okay, I'm curious, what do you think happened? So my variable was participant and observer. What do you think it looked like?
I think they're almost the same with the observers.
I think the observer didn't do a lot to avoid the mistakes done.
There's your participant, and there's your observer.
See.
At no point in time was there any significant difference between any point in time. Observers gained just as much from watching the sim as those that were in the sim. Observers gained just as much as those that in the debriefing as the participants in the debriefing. There was one significant finding: time. So the test that I ran created a variable, which was really cool because I don't think I saw that coming. One of the things about doing this is you don't see a lot of things coming until you do it. When I ran the test, I got this new variable called time because I ran a repeated measures analysis of variance with the help of a statistician, by all means. I ran a repeated measures analysis of variance, and it creates a variable called time. And it was significant with a very high effect size, indicating that there was a significant difference between all 4 time points. This is great for the educator. This is great for the clinical educator, that sim produces that drastic of a gain. But what I'll talk about at the end is there was significant decay 4 weeks later. So as early as 4 weeks, there was significant decay in knowledge. So as you can see here, the time by role, time by site. So I also wanted to make sure that there was no differences between the 2 sites that I ran it between, just to make sure that my participants in one group in one city were pretty similar to the participants in the other group. And then I ran time by role by site. And as you can see on the significance column, 0.354, 0.286, 0.397, anytime role or site was in there, that was a non-significant finding. The only significant finding was time, indicating that all of those interventions, whether it be the sim, the debriefing, or time till the next test, those were significant. There's another one when I was looking at between subjects effects. Again, you can see the significance for the intercept being the time was 0.000. My other one's site was almost, I mean, we approached a little bit of And it wasn't significant, but that was the only one that kind of got close. And then if you look at that n squared, that 0.983 is the effect size, and that indicates kind of the magnitude of the findings or the magnitude of the significance of that. So research question 2. So now this is related to the applied case. So in the applied case, this was their knowledge about anaphylaxis after debriefing and 4 weeks later. Participant, observer. No significant difference. Significant decay. So why does this matter? So I'm not going to get into much of the whole, like my favorite thing of this, to be honest, was the theory. And I never thought I would say those words in the same sentence. But I loved the theoretical findings. It was like once I found a theory that I loved, I actually got to, I emailed Dr. Kolb, and he emailed me back and said, feel free to adapt my framework. I'd love to see your work. That's probably one of the coolest things in the world. And you know, I was encouraged by faculty here and by my faculty at IU to just reach out. Sometimes they're willing to listen, or, you know, and so they just said, yeah, we would love to read it, adapt it like crazy. What I want to say to you, in whatever role you're in, we know from this study in education that as quickly as 4 weeks after a really good intervention, and that's and I say really good, not just talking about me, but talking about your best teachers, talking about some of the best learning environments that you've been in, knowledge can decay as quickly as 4 weeks. And we know that exists because of the vast amount of literature on CPR. So have any of y'all implemented RQI? Yes. All of that is coming around with knowledge decay. We know that, and I understand that's it's in a code situation. And so there's an element of crisis that's coming with that. But we're finding that as quickly as 3 months, your ability to compress and recoil decays significantly. Not necessarily your cognitive knowledge, but just your ability to do it. And I mean, in some cases, your cognitive knowledge. So there's this idea out there that we need to conceptually, and so I think that's what RQI is trying to do, is link them closer together. So there's an idea in nursing education, there's an idea in clinical education that, you know what needs to happen is the students in this study that did the opioid-induced respiratory distress situation, how many of you moved in your nursing education curriculum from respiratory to cardiac to endocrine to, I mean, it's some form, and well, you've learned that, you learned it last semester, we're moving on, right? We hear those words all the time. You learned that last semester. We hear it on the clinical unit. Did you not learn this in nursing school? It might have been that they were, and what my finding from this is going back to the advertising literature. They may have been exposed to it. It doesn't mean that they grasped it. It doesn't mean that their attention was so on point in this saturated curriculum. How many of your books were, I mean, yay high going through nursing school? There's no way they can saturate all of that. So what we know, what we're trying to do is teach them very frequently. You're having to adjust for something that you might have learned, but you're having to adjust your frame for a slightly different situation. So what would be best is that if these students, let's see if I can go back here, right here at CE post-test 3 and AE post-test 2, and this is, they always teach you in your PhD, what's the next study? The next study is to do the anaphylaxis sim and ask them in debriefing, what if this patient was a 47-year-old post-abdominal hysterectomy, and they go, oh my gosh. And I did that, I just didn't get to study it, because they will teach you in your dissertation program to keep your study small. So easily I could have extended this. But the idea that once it's covered, it's been learned, is being very, very, very well challenged by CPR literature, and we're finding it in even our own. We can expose them to it, but rather than saying, you know what, they had the respiratory sim, well, let's do a cardiac one. Now let's do a diabetes one. Now let's do a whatever one. That there should be some common thread between them all that you kind of help them to build. So you could put this, so I begin to think, this is where you get to have fun as an educator. I begin to think about how many times we could relate this case to respiratory distress. So the world that I really don't know, that I started to talk about at the beginning, is the OB world. Any of you OB nurses? No? Okay, so you may be with me on this one. But apparently mag toxicity looks like respiratory distress. They stop breathing. It looks like opioid-induced respiratory failure. They need oxygen. They need an antidote. Their lung sounds decrease. Congestive heart failure. We don't really think of the antidote being Lasix, but it looks a little more like the anaphylaxis situation, right? Heart rate goes up, respiratory rate goes up. Their lung sounds are not clear anymore. They're crackly. COPD. Think of any situation of respiratory distress, how you can relate it to a different body part or a body system and conceptually link that for learners. That was the biggest finding for me in this, is that we should consider, rather than have covered the content, move on, we've got to link it together. The limitations, because of the control of the study, one facilitator, that was me for the debriefing and simulation. I was familiar with the knowledge questions, so if I were to replicate this, it would be really good if I had someone else who didn't know the content of my exams. But again, for optimal control, I needed to do this in this first study. And again, the students were familiar with me. They knew who I was. And so that could also be a factor in the attention piece. They just know who I am. Who's to say that if someone from they have no clue who that is, the same things would happen. But that's part of the next study. I'm really interested in the attention and motivation portion. We pre-brief learners, and so we actually think this is where we capture their attention. And there's a lot of work that's coming out where we learn best by stories. And so a lot of times what we've been trying to do is record a story about who this patient is. Because when I tell you a 57-year-old female with congestive heart failure, you begin to develop a picture. Our students don't. They don't really know how to build that picture. And so we think if we begin to tell them a story at the beginning, not only about who the patient is, how many of you cared for a patient maybe in your sim experience and the mannequin's name was Robin Williams, or maybe something funny like we have Dolores Dolor, and it's all a pain scenario. What we're finding is that that's very unrealistic for students, and that if you actually tell them that the 57-year-old female is a widow and she has 2 dogs, and you start capturing their attention, they start, and especially us as nurses, we start thinking about someone we've cared for. So that's really interesting for me to consider that. I obviously didn't evaluate the motor reproduction. One of the next studies for me is I'd like to get the faculty in the room, demonstrate the expert, followed by the novice, or the novice then followed by the expert, and see how that impacts motor reproduction. Of course, the goal is a multi-site study with blinding to the instruments, sequencing simulations, and then the whole work around deliberate practice, again, goes back to sports. Deliberate practice coached by people, constant, repetitive for mastery learning. I think that we're ready in nursing for the term deliberate thinking practice, not just skills practice, but it's been a long time since I've recovered a heart, but I have a feeling that because I did it so much, I could probably quickly adjust back to that. Where I would probably be the most unsafe is with a sepsis patient, because I saw them so few and far between that you can't assume that just because a nurse has had critical care experience that you can float them and they're going to pick up on all the subtle changes that we pick up. And so this idea of this thinking practice is really astounding to me. Lastly, it advances the science of learning through observation. It deepens the theoretical support. It provided support for the Anaxel standards of best practice. And as they try to do, and this can't always be done, I was really, really blessed that this was the first repeated measures experimental study with true randomization. And so as I go to publish this, their goal in a PhD study is to get you to add to the literature, not this new, there was about 24 people before me that looked at the difference between observers and participants. The limitation is they did it at one point in time, and they didn't randomize their students. And so if you've been through your research or you've been through statistics courses, you know that there are limitations that surround that. So my advancement was not this novel idea. 24 people had done this before me. It was just a slight adjustment to the method to provide a little bit more of a conclusion about it. Like now then we've randomized it, we've done 6 points in time, and there's really no significant difference still. So I know I wound up going almost the full hour, but that is the end of my presentation. Do y'all have any questions?
Dr. Decker was supposed to be here from Texas Tech to give anybody a response, but she's out of town or had something come up. So any questions for Dr. Johnson?
I would just say, you know, when I was talking to Dr. Long about this, the idea for this began here. And I think that sometimes when you hear this, you think, you know, like I said, the drawing of that framework was multiple times. And as I was telling Dr. Long, when I came and met with her the first time about my design, so I finally got to the verbiage, experimental, pre-test, multiple post-test, repeated measures. When I first met, I think I was about the 30th iteration. And what does this look like? And we were looking at this crossover design, and Dr. Long helped me kind of think about that, and I presented that. I presented it for my proposal defense. And my team was really impressed with it, and I always think, you know, when you think about defending something, you think they're just going to, you know, you're done if you don't. And, you know, they really worked with me on, that's a good design. I think it's down the road. Let's rein it back in. Let's try and get this to be a little bit smaller and less convoluted. And it wound up being really clean. And it provides data that would then inform the study that I think Dr. Long and I were looking at. And so it didn't just happen. Even though I'd been through the class on quantitative design or things like that, it was just teachers pouring into me. And that really kind of began here. I especially around my own, I mean, the BSN is completely different. Teachers poured into me on clinical knowledge. When you start thinking about changing practice or changing things, here is where people begin pouring into, yeah, create something like that. This whole idea of creating something or developing a project on your unit or developing, mine was about therapeutic hypothermia. And so in that I found SIM, and it kind of catapulted me into this idea of looking at what is it about simulation that helps people learn? So sometimes I think those moments that spark interest, and what I'll share this also, when I was at the NLN, the National League for Nursing conference in 2013. So I had just presented a poster through my MSN on developing a simulation on therapeutic hypothermia. And when I sat there, I noticed that the Mary Ann Rizzolo Doctoral Research Award went to somebody who developed a simulation around therapeutic hypothermia for their dissertation. So way more involved and a lot of more sample size. And I think I messaged Dr. Long and I said, somebody did this. Like, that's really cool. And they won an award for it. And so then my faculty, when I started designing this, encouraged me to apply for that same award. And I was like, there's no way. Like, absolutely no way. And so then when I got the email, I emailed Dr. Long and I was like, who would have thought 4 years before this I would have even knew that such a thing existed? And then that happened. So it was, I don't know, my PhD, people are very intimidated by it. It was one of the most rich learning experiences of my life. And I had an advisor change and I had all these things that kind of got in the way that people tell you rough stories about. And I had people that just poured into me and really got to do something a lot of fun. And I would have never thought, I think in my BSN, that research could be so much fun. But when I saw the data come out, first I panicked. I was like, there's no difference. And I was like, wait, but that's okay. There's no difference. And you begin to think about it and what does that mean? It's a lot of fun and a lot of tiring nights, but I would encourage it. It was a very rich experience and people just poured into me throughout my entire educational experience. And I think that that's something that through attending LCU, you get to feel that support. I felt the same thing in my PhD program. People that just loved on me and wanted to see me develop into whatever phenomenon I wanted to study. that all kind of begin here. And so I would encourage you to go on because it's really neat when you start seeing people, interested in your work and you're presenting at, different conferences and they want to replicate your study. It's a lot of fun. So I hope you're encouraged. I hope you learned something. And if you're in the clinical setting, I think like I said, the biggest thing that I learned is just because it's been taught, don't assume that it was actually learned. We see that, I think, all the time, and now we have tons of data like RQI to support that. So, all right, thank you all so much.